introduce you to the team. So myself, I'm Achim. I also have a personal connection with your country because I did my first fellowship with a grant in Graz. So a significant part of me and my professional career is thanks to you. So it's really a pleasure and an honor to be and to give something back after some years. To my left is my friend and my partner in crime, Mihai Cocoi. I think you know him. He's the guru of CTO. He knows all the materials. He wrote this famous book with Mihai Kovacic. And besides a very good operator, he's also a very great artist. He knows how to draw very nice graphics. I will show you, Theo will show you some nice drawings of the coronary of our patients. It's nice because when you draw something, you also understand better the anatomy, and I think it helps you with the plan as well. So to my right is Theo. He's our fellow. He's going to show you the life case. He's very enthusiastic. Actually, he found the patient, so thanks to him, we are saving this patient. On the nursing side, we have Claudio and Delia. They are really great. And outside, it's a very enthusiastic team as well. We have Maria Luca on the ICU side. She's also helping us a lot. She's our partner in crime in every difficult case. She makes sure that the patient is stable all the way, and most importantly, he's quiet as well. And we also have Theophile, who just installed this new video transmission system. He worked like crazy in the last week, so I want to also thank him a lot. So with this, I give the word to Theo, and if you can switch to our presentation case, and we want to show you the case. Thank you.
Thank you, Alex. Yes, so for today, together with the two great operators, we prepared a highly complex, highly interesting case. We named it multivascular disease with a twist. So our history with the patient started on 13th of April. He's a 77-year-old male patient, an emergency transfer from a county hospital complaining of resting angina with sudden debut with mild dyspnea. From his medical records, he is known with type 2 diabetes mellitus, hypertension, and COPD. No other relevant cardiovascular history. He was hemodynamically stable with no signs of acute heart failure. Also now he is still stable. Here is the EKG. You can see an STE elevation in D2, D3, and AVF of 0.5 to 1 millimeters. It's quite discrete, but it was there. So at the transthoracic echocardiography, we had a non-dilated LV with a mild systolic dysfunction with an ejection fraction of 45, with no signs of mechanical complication. He had a significant troponin dynamic with moderate renal impairment, and so with a working diagnosis of acute coronary syndrome, so an inferior STEMI, emergency coronarography was performed. Now let's see what we are dealing with. Baseline coronarography. We see a right coronary artery with very calcific, severely stenotic mid-RCA lesion. Also a distal lesion in the posterior descending artery. Here another incidence. You see quite a long, very, very calcific lesion. Now switching to the left side from caudal, you see that the left main and circumflex are only moderately diseased, but at the bifurcation, you see that the left, on the bifurcation, we see that we have possibly an ambiguous lesion, possibly a calcific nodule or a very large trigon of confluence. We did not know at that moment what it is. Now, from cranial, you see a highly diseased ostial LAD, also proximal LAD, and midsection LAD with significant dilation of the mid-LAD segment at the bifurcation with D1. Now, to get a better view, we switch to a cranial left anterior oblique, and you see how severely diseased it is, the LAD, with severe aneurysms, also pre and post-stenotic. You see how D1 actually emerges from the aneurysm. It is quite a tight angle after that, so we anticipated pretty hard wiring through this lesion. Now another images from spider, just only to check again the circumflex and the left main. you see some haziness, and at this point we were not sure whether we had a severe calcific nodule in the distal left main, or is it just a very large osteal circumflex with a large trigon of confluence. Okay, so we stopped the index procedure and we did the hearting with the surgeon, whether the surgeon would accept the patient. It is, as you would guess, a highly complex, high-risk patient with a syntax score of 59 for PCI and 62 for KBG. An operative risk of 10% for isolated KBG, but the discussion was stopped short because the patient refused any kind of revascularization and decided to sign the discharge papers against our advice. After 2 weeks, he got back to us. He had a change of heart. We resumed the discussion. He still refused any kind of surgical revascularization, so we had to do it through PCI. So the main challenges are, in this case, the fact that most of the vessels are severely affected with lots of calcium. The LCX looks fine, but we need to take into account provisional stenting technique involving the left main and LAD. The anatomy is quite ambiguous. We need further clarification. The mid LAD with the difficult wiring I mentioned, and also the patient had the difficult access with the kinking in the radial artery and a tortuosity in the subclavian artery. Also the recent acute event. Now we did, to further prepare the case, we performed a coronary CT angiography. As you can see, we see the severely calcific lesion in the LAD, just as we predicted, with a lot of calcium right on the aneurysm at the bifurcation with D1. But as a good news, the fact that we have no calcific nodule on the bifurcation of the left main, you see it's just a very large polygon of confluence with slightly dilated ostium of the ACX with not so much calcium. The RCX is just as we expected it to be, with a bit more calcium in the proximal side than we expected. Now, but the ostium is fine. Now, here are the drawings made by Dr. Mihai Cocoi, very talented, as we can recapitulate, so we can resume all the lesions that we have to deal with. And now for our plan, of course, we are very ambitious. We plan a full revascularization of all the lesions. The summary of it was to employ a calcium modifying technique both in RCA and LAD, maybe rotablation, but it was the plan at first. Everything I was guided, but my colleagues already started the procedure and they did some changes on the course for the plan, and I give the words to them for discussion.
Yeah, thank you very much. Also, hello everybody. Thank you for inviting us. So you saw the patient, you saw the lesions. Maybe it's a good option now to stop and discuss the case and discuss strategies, and then we can show you what we did so far and what we have to do from now on.
Can you hear us, Stefan?
Yes, okay, this was a very nice preparation of the case, a very nice presentation, and I think it's very reasonable. Also, it's a modern approach, you know. You have the time to include also the patient's will and the patient's sorrows, so it's not just that, this individualized medicine, which I experience here. So I want to ask the panel, actually. I want to ask Anna, if how would you approach this case? How would this be in your hospital?
May you allow me another question before?
Absolutely.
We were discussing this, the surgeon and me. Why this high mortality rate for the surgery, about 10%? We didn't get it from the presentation.
So maybe if we had been discussing that, I would like, this meeting is also about the surgeon. I might ask the surgeon just to tell his view of the case.
From my point of view, from the facts we saw previous to the opting of the patient, this would, in my view, be a surgical candidate because he has complex lesions, he has a left main disease, he has a multivessel disease, and he's a diabetic patient. So these are all factors in favor of surgery in these patients. Then, as Anna said, we were wondering about the 10% because, of course, 10% operative mortality are something where you understand the patient opting against surgery, but I did not see the comorbidity which really drove this 10% mortality.
So your estimate, as far as you are informed now about this case, what mortality would you expect?
1-2%.
So really low. So,
yeah.
Okay, so maybe the suggestion will be that this patient should also see the surgeon, talk to the surgeon, because if you look at the syntax, it's rather close. If you just go by syntax score, I think we have the choice. We can offer the choice. But I think it's a very good statement that we should offer the patient also the chance to talk with the surgeon. Tim?
Yeah, I would really appreciate the chance to have a surgeon on site right now, because I was just trying to figure out what the reason would be to refer this patient for surgery. Because, and now I would really appreciate your comment. When we look at the posterior descending, there was a heavily calcified lesion in the mid of the vessel. So I just asked myself, is this a good target for the surgeon to put his graft on? That's something that you can comment on. Then I see the circ, which is, from my point of view, not really severely diseased. Well, as I'm always the physiology guy here in these meetings, I think if we would do like an investigation doing IFR or FFR, this would maybe not be a vessel with a significant stenosis. And then there's the LED, which is obviously a great target for a lima or something like that. So what would you consider the posterior descending?
Yeah, I agree with you that the posterior descending is at least a borderline target. However, you have the lima LED, which is in any way the working horse. So maybe in such a case, you even could discuss a hybrid approach. So this also would be debatable, but I think we still know too little about the comorbidities of the patients, because this 10% is still a question mark. And another point, which also we brought up in the discussion, is this patient was presented as a STEMI and then waited 21 days. Would you do that?
No, I think obviously not. But however, I was just trying to figure out which might be the culprit lesion for the STEMI.
Right.
But just to come back to what you just mentioned, because from the experience that I have with our surgeons, I think this would really indeed be a good candidate for a hybrid approach with a mid cap on the LAD and then an interventional treatment of the right. But you agree that the circumflex is obviously not a great target.
I agree.
Okay.
So I think we are on the borderline for this. It would also depend, I have to tell this also, because it will depend on the expertise, on the local expertise. So there will be surgeons that say, oh, this patient has calcified aorta, we cannot do the clamping. Others will be able to go axillary or different approaches. So I think it's also depending, and if you know this from the syntax trials, how different the quality of the treatment was, both in the interventional and in the surgical field.
That's also why I think this case should be discussed interdisciplinary, because if we go for a hybrid approach, for example, lima LED is also doable in a rather easy way in an off-pump technique, where you do not even need to touch the aorta. So if we go in this direction, this would be a good option. But again, in the end, the comorbidities really would be interesting, because somebody obviously calculated this 10% mortality, and there must be some factors we don't know at this time point.
I see. Okay. So I think there will always be open questions, which is not a big deal, but I think the more we interact as surgeons and interventionists, the better will be the offering to the patient. I don't know about the psychology part of this. It was difficult for the interventionist to get the patient to cooperate, and it will also be necessary for the surgeon to approach the patient in a way that, I mean, maybe it's easier even for the surgeon. There's the anesthesiologist, the patient will sleep, so maybe this is even better, but then you have the rehab after it, you have the phase where he's in intensive care maybe, because it's not that trivial. I think we agree that it's not a trivial case. It's some challenge. Okay, did you hear us what we were discussing?
Absolutely, Stefan. Yeah, exactly. And just to to acknowledge the elephant in the room, this is a surgical case, absolutely. But as you said, this is a special patient. It's a unique case. He doesn't want any surgery. He came with STEMI 3 weeks ago. It was some ST elevation. It was not much, but it was 1-2 millimeters. He had an important rise in troponin, and he refused everything. So, like you said, I think it's really important to look at the anatomy, look at the patient, and make a plan based on that. Just a short comment about the risk. He has COPD, eye-controlled diabetes, recent acute coronary syndrome, and really bad peripheral disease. He has iliac disease, so we need to keep it radial for him. That's why the high surgical STS score. What else, Mihai?
So problems here now are, of course, we can try to do hybrid, we can try to do PCI, we can try to do surgery. I don't think it's a matter of technique. It's a matter of getting a good result in order to have a good long-term result, given the fact that the patient is 73 years old. 77 years old, sorry. And the problem is calcium, really. So if we go for a PCI strategy, the main issue here is prepping the vessel properly in order to have a good stent expansion and apposition in order to have good luminal areas and to have a good long-term result. That's why everything that we try to do with IVUS. Another issue that we might encounter is the polygon of confluence, which we had a problem with, we didn't know exactly how to treat it, but we know that it's just an aneurysma. And as you previously mentioned, the circ is not diseased, so not severely diseased. The LAD is full of calcium in the proximal part, we agree, but I think we can try to treat this as good as possible and obtain a good result. And in case we fail to do that, there's always the option of a lima on the LAD.
Alex, thank you for illustrating also this operative risk. I think we can a little bit better appreciate now how they came to that number. And we do have actually a comment from Tim.
Yes, please.
Yeah, first of all, I would like to congratulate to your proper preparation of the case. I think the CT and trying to gather as much information as possible was extremely helpful in this case. Coming to technical terms, I think the right coronary, even if it looks nasty, is the easiest problem to deal with. It's quite straight ahead, so it's calcified. You can do rota, and then it will be. I think the really problem will be, as you said, the LAD, because you will have this focal lesion at the beginning, and then you will have a gradual pressure drop. So the question is, when it is, we will have a lot of negative remodeling, lots of calcium. So when you treat it, where do you start? Where do you stop? And I think to figure out this will be one of the major problems next to the problem how to deal with the calcium in the region of the aneurysm.
Alex, I think we're at the point now where we let you work at this. And I would ask you to just tell us if there is something special going on that you want to show.
So, can you guys hear us?
Yes, we can hear you.
So, we have because of the concomitant peripheral arterial disease, we have a single axis right radial standard 7 French system, and we decided to go for the RCA, which we considered to be culprit of the acute coronary syndrome that happened 2 weeks ago. So we expected a lot of calcium. We went with an Amplatz left 1 7 French guiding catheter, and then we wired the lesion with a hydrophilic pilot 50 wire, which was somehow difficult to do, but we managed. It was a lot of friction between the wire and the lesion.
We still use the pilot 50, Stefan.
Oh, you do? I still don't know this wire.
No.
Okay.
It's our hydrophilic wire.
I know it, but I don't use it.
We said that we would do upfront rota for the RCA, but then we tried to pass a small 2.5 balloon, which we managed to pass it down. We inflated, and then we took a cutting balloon And we did like the RODIN-CUT technique, which we published, sequential inflations of the cutting balloon on the whole proximal calcified segment. And
So it's
then
a cutting, a Wolverine, or what kind of?
Wolverine, a Wolverine
Yeah, okay.
balloon. It was a trio Wolverine balloon.
Okay.
And this was the result after the first cut. And then we went ahead and pre-dilated again with the 3.5.
This is a 3-0.
This is the yes.
3-0.
And then 3.5 non-compliant balloon. And then we did an IVUS run to see what we've done. This was the angio after cutting and pre-dilatation with the non-compliant balloon.
Yeah, this is a 3.5 balloon actually.
Yeah, this is the 3.5 balloon. You can see there's a bit of waste in the middle of the RCA, which is the lesion which was tougher to cross.
But let's show the IVUS, because we chose this 3.5 balloon according to IVUS. So between the 3.0 and 3.5, we did an IVUS run. If you can show the IVUS number 3. So this is this IVUS, you can see circumferential calcium almost 360 degrees, is 200 degrees. Very thick calcium. We cannot see anything behind. We can see those reverberations. It's somehow cracked, but not fully. Can you see the IVUS, right?
Yeah, we can see the IVUS. We see cracks.
And then if you can show, I think the next one, we measure. No, the next one is from stent. IVUS number 2. No, 2. We measured that the vessel is 4.0. So we said, okay, we take a 3.5 balloon, and then we dilate high pressure, and then we check again. So Stefan, we thought this is gonna be a hard ride to do, but actually proved a bit easier. Only balloon based and cutting of the calcium, which shows that actually this was the culprit back then.
What pressures are you applying with this Wolverine?
It was going 14, 16 millimeters, so high pressure inflation, and at least 3 or 4 inflation per lesion. So we don't take the Wolverine out, we inflate and go down, inflate again, go down to 14, 16 atmospheres, with the Wolverine being undersized with half a millimeter.
According to IVUS.
If the IVUS is 3.54 millimeters, we went with a 3.0 Wolverine, and then pre-dilated again after the Wolverine with a 3.5 non-compliant balloon. And then we did the IVUS check and saw that the lesion was correctly prepared.
Are you familiar with the RODIN, Stefan?
With the Wolverine?
With the RODIN technique. It's a technique used with the Wolverine, with the cutting balloon. It's
it's a technique that we saw. We did in a live case in Switzerland recently. And I realized that I myself was going maybe up to 16, but not more, because the company is telling us it's rated burst 12 and it's nominal 6. So from the Lucerne group, I learned that undersizing and over pressurizing it is feasible.
Exactly.
And yes, exactly. We can't leave it like this. We are not worried about the lead vessel. So we were sure it will heal.
So we applaud for the right.
Yeah, but
and we want to see the left.
So after that, we just before coming live, we put an EBU 3.75 in the left. We put a protection wire on the circ just to have a good anchoring and backup. That's it. And then there was the problem with wiring the LAD. And then again, we took a hydrophilic wire, and so basically this was the real live wiring. So not that difficult. So a lot of friction and tension whenever we passed into the aneurysm. And then we had our idea was to trap and put a micro down and exchange the hydrophilic wire with a workhorse or extra backup wire. However, when we tried to advance the microcatheter got stuck in the ostial LAD. So the microcatheter would not even reach the mid part of the LAD.
We even lost everything.
And while pushing, we lost everything. We lost the position. So we had to rewire everything. So we had to go back and we rewired again the LAD with the same workhorse wire. Not as difficult as expected. However, we had difficulties advancing equipment. So we took a 1.5 millimeter balloon just to try to make some room and recover the position of the guiding catheter. And then we upgraded to a 2.0 millimeter balloon, which is this one, the one you see on the screen right now. We
Really hard to.
pre-dilated also distally to that S-shaped aneurysm. We pre-dilated into the aneurysm. We pre-dilated the ostial part of the LAD.
Look at the calcium.
You can see the calcium here. And now we plan to pre-dilate with the 2.5 and then go with the calcium modifying technique that will not create perforation in the S-shaped
I have to ask
aneurysm.
for Rota, you know.
Yeah,
Absolutely.
sure. There has to be this question. But on the other hand, there has to be the safety issue discussed. And I think you
Yeah, but it's safe.
very concerned about safety because you said
No, I think
you
now.
have
Yeah,
But
sorry.
it's going to be very difficult if you don't get rid of the calcium there.
Yeah.
You're going to have
I know.
very not a good stent result afterwards.
But is it Felix, a bit too late to Rota now?
No, I think you still can get rid of some edges. I mean, you can do IVUS and estimate it on the IVUS, but I would definitely try to get rid of some calcium there.
But what we can do now, we can try again with the micro, see if we can get it down, and then we can think about it.
Stefan, I would say the indication for Rota comes at the point where you can't cross them with the microcatheter is usually an absolute indication that that's when you need the rotablation, isn't it?
Absolutely.
Helen, thank you for this. It's relative and absolute indications. I fully agree. But I think Rota, if it's not angulated like this, everybody would enjoy the ease of Rota just to get rid of this inner calcified part and then have a good, have an easy preparation after that. But I myself would also think about risk here with the FSCDS shape. And you're mentioning shockwave, you know, and we now have the Javelin come.
Yeah.
So maybe this will be a useful tool if we are aware of the risk of Rota, we'll see. Everybody knows about Javelin, about the forward shocking. Are you using this? So Sarah is looking forward to that. But the surgeon wants to say something.
Again, I would like to add that what we discussed previously, that still, when I see the course of this case, I still would bring the idea up about a hybrid, because the LAD, in my eyes, would really benefit from a Lima graft there.
That's great, and we will have Sigrid Sandner from New York talk about hybrid soon. And I think we have discussed a lot now.
The idea was that while we were discussing, we also had somebody mentioned that, and it was a very, very nice idea. Somebody mentioned to do the Rota only on the proximal LAD, but while we were discussing, we exchanged with, we put the microcatheter down now, which you can see it goes down fairly easily. We will exchange for the Rota wire, and then we will Rota the whole thing. And
So are you, yeah, okay, so you show us later. You follow the provoker, I see that.
Yeah,
Okay.
sure, why not? We can do whatever we want.
Yeah. I know you're very skilled. So actually, we let you work now. We'll look at this later. You take your time.